Alterations in neuromuscular function. So now we're looking at that peripheral neuromuscular junction. So we have alterations in muscle tone and movement. So hypotonia is decreased muscle tone shown by passive movement of the muscle against resistance. Could be related to cerebella and pyramidal tract damage. Hypertonia is increased muscle tone shown by passive movement of the muscle with resistance. Basically, spasticity is a type of hypertonia, and that's hyperexcitability of the stretch reflexes. You can also have rigidity, which is classified under hypertonia, is that the involved muscles are firm and tense. There is an increase in muscle movement and even uniform passive range of motion. Hyperkinesia is a excessive movement. Dyskinesias are abnormal involuntary movements. Hypokinesia is decreased movement. There's a loss of voluntary movement despite conscious and normal peripheral nerve and muscle function. That would be like akinesia, paresis, bradykinesia. Akinesia is a decrease in associated voluntary movement. This is a dysfunction of the extrapyramidal syndrome, and that may be related to dopamine. So bradykinesia and Parkinsonian diseases, Parkinsonian classification under akinesia. Dystonia is maintenance of an abnormal posture through muscular contractions. Tonia or Gegenhalten is known as the inability to reduce or relax muscle tone. So Huntington disease is a big one for this. So this is an inherited progressive neurodegenerative disorder characterized by those coriform movements, psychiatric problems, and dementia. Autosomal dominant, high penetration, clinical manifestations, age 25 to 45, prevalence is 2 to 8 per 100,000. Europe, North America, lower prevalence in non-European ethnic groups. A lot of the symptoms begin insidiously, and the movement abnormalities and psychiatric and cognitive features are. So chorea is the key feature of Huntington's, and it's the defining sign at time of diagnosis is that chorea. Psychiatric problems are irritability, depression, dysphoria, agitation, apathy, anxiety, paranoia, delusions, and hallucinations. So you diagnose on the basis of the typical clinical features. Is there a family history of the disease? And confirmatory genetic testing, which is that CAG. So there are 3 stages: early, middle, and late. It's a slow but relentless deterioration of that cognitive and motor function. So Parkinson is a commonly occurring disorder of movement, primary or secondary. Secondary Parkinsonism is caused by other disorders. Other disorders could be head trauma, infection, atherosclerosis. Primary begins after the age of 40. The incidence increases after 60. More prevalent in males and is the leading cause of neurologic disability in older population greater than 60. Prevalence is 1 in 272 persons. About 60,000 cases new each year. Pathogenesis is similar to a lot of these ones in the neuro system, as we don't know. It is unknown. There have been several genes that have been identified, and there also is suggestion of a viral and environmental toxin etiology. Basically, there is degeneration of the basal ganglia. With that dysfunction, there's a misfolding of the alpha-synuclein protein, and that is a loss of dopamine producing neurons. We talked about dopamine early, that is high in movement. So that is in the substantia nigra, and there is a picture of that. So you can see there where it lies within the brain in the superior colliculus. We have a non-Parkinson and a Parkinson. That is the substantia nigra where that dark area is. So there is a loss of neurons in that area, as well as the dorsal striatum. That resulting depletion of dopamine, which is inhibitory transmitter, then allows for cholinergic excitatory activation. So we lose the inhibitory effects of dopamine, which allows for the spasticity of the feedback circle, and that leads to hypertonia, akinesia, as well as abnormal movement called Parkinsonism. You can also get dementia over decades because of the infiltration of Lewy bodies. Clinical manifestations are tremor, that resting tremor, rigidity, muscle stiffness, bradykinesia or akinesia, which is changes in movement, postural disturbance. They have that kind of stooped over posture. There can be some autonomic or neuroendocrine involvement, which is inappropriate diaphoresis, orthostatic hypotension, drooling, gastric retention. There will be no weakness, though. So you can see here, we lose receptor, we lose transmitting neuron, release of the dopamine, so decreased dopamine, which is inhibitory, and that it leads to all of these symptoms. ALS, amyotrophic lateral sclerosis, diffusely involves the lower and upper motor neurons, resulting in progressive muscle weakness. Amyotrophic basically means without muscle nutrition or progressive muscle wasting, and that is predominantly in the lower motor neuron component of the syndrome. Lateral sclerosis is scarring on that corticospinal tract in the lateral column of the spinal cord. Classic ALS, which is Lou Gehrig disease, may begin at any time from the 4th decade of life. Peak occurrence is early 50s. The male to female ratio is 1.5 to 1, so not too much. And then it actually equalizes after menopause, so it'll change to a 1 to 1. So we have that progressive muscle weakness. It can start in the limb, axial, bulbar, or respiratory muscles. And then it generalizes relentlessly, which is causing progressive disability and ultimately death because of respiratory failure. The cause of the motor neuron death in ALS is genetic mutations in the copper zinc superoxide dismutase on the glial cells. So remember that superoxide dismutase was the combatant to one of the free radicals. So basically this is major free radical damage within the junction synaptic cleft area. Death of the motor neuron results in axonal degeneration and secondary demyelination with glial proliferation and sclerosis. There is a small percentage that may live 10 years or longer. Poor outcome with this one. TBI, be aware of this in relationship to sports. As well as mechanism of injury, mechanism of the accident, any trauma to the head with or without injury to the brain, minimal, minor, moderate, severe, based on symptoms after the injury. Minimal head injury are those with trauma to the head and no loss of consciousness, normal GCS, and that's going to help you delineate the severity of it. So your Glasgow coma score from 3 to 15, 3 basically means you're dead, 15 means you're normal. Eye-opening, verbal response, motor response. So you get 1 point for none. So basically, if you have none of these, you get 3 points, but it basically means you're dead or on the way. So be aware that the Glasgow coma scale is one of the mechanisms that you will use to diagnose severity. Subdural hematoma is extraaxial blood collection between the dura and arachnoid layers, maybe due to arterial or venous bleeding. Most often it occurs because of those bridging veins traveling in the dural venous sinuses rupture. Usually traumatic, consider AVM or a fistula. Epidural, usually trauma, accidents, falls, assaults. There are usually a skull fracture associated with it, leads to that dissection of the artery. And there is a picture of it. So skull fracture, we have epidural, and then we have subdural tearing of meningeal artery, and that's what leads to the epidural. Subdural is slowly expanding. Usually this is related to a bridging vein. Arterial, epidural, arterial, subdural, venous. Easy way to differentiate them. DAI, diffuse axonal injury. This is a direct impact or rapid acceleration, deceleration of the head. Again, Contra-Q can help with this one, delineate this one a little too. Headache, vomiting, and they may rapidly deteriorate of the GCS and into coma. If they're severe enough, will present with altered mental status and coma. Traumatic subarachnoid hemorrhage, direct impact, rapid acceleration, deceleration due to a fall, must rule out an aneurysmal subarachnoid. So I did put the concussion mild TPI diagnosis as well as guidelines here for you, but it basically gets down to, do you scan, do you not scan in patients with a minor TBI? Often difficult to, so I put the kids in here. So we have a greater than 2 years and then less than 2 years, PCARN, and this is what they look at to say that scanning okay, because we don't want to give that much radiation to little guys. So this is more related to younger kids. Post-concussive syndrome, common sequela of traumatic brain injury, especially concussion. Mild concussion can even result in this. And headache, dizziness, some neuropsychiatric symptoms, and cognitive impairment. They should resolve and improve within 3 months after the initial onset. Infections of the CNS, bacteria, virus, fungi, parasites, mycobacteria, all pretty much can infect and inflame the CNS. They gain entry, one, by hematogenesis, which is blood, or a direct extension from another source. They produce disease by direct neuronal or glial infection. Mass lesion formation, there's inflammation with edema, interruption of the CSF pathways, neuronal damage, vasculopathy, and then secretion of neurotoxins. So big one here is meningitis, inflammation of the brain or spinal cord. Causes include bacteria, viral, fungi, parasite, or toxins, may be acute, subacute, or chronic. Pathophysiology, clinical manifestations, and treatment differ due to the microorganism that is causing it. Bacterial is the worst, and that is usually Neisseria meningitis or Streptococcus pneumoniae are the most common causes of the bacterial, and that's about 1.3 per 100,000 affected annually, predominantly in men and boys, and in the fall, winter, and spring of the year. Issues with being in close quarters, and that's why you get your meningococcal before you go to college, because you're around close quarters and lots of people. Young persons and those over 40 are mostly affected. What predisposes you with that direct invasion is sinusitis, otitis, immunocompromised, and pneumonia are how you would get that from direct instead of homogeneous blood. Aseptic meningitis is also what we call viral meningitis, and this is non-purulent meningitis, and that is believed to be limited to the meninges. It produces various symptoms, and it's not as severe as bacterial. Fungal meningitis is chronic, much less common than bacterial viral, and this is with usually impaired immune systems, and that usually develops insidiously over a couple days to weeks. Either a systemic or bloodstream infection or direct extension of that cold or sinusitis. Then they have large numbers of neutrophils recruited to subarachnoid space, relief cytotoxic inflammatory agents, bacterial toxins, that good old inflammatory response in the meninges. So then the meningeal vessels become hyperemic and increasingly permeable. This then thickens. There's exudate, it thickens in the CSF, and then that alters normal CSF flow. The meningeal cells become adenomous, more exudate, and that leads to increased intracranial pressure. You can have engorged blood vessels, and thrombi can disrupt blood flow, causing further injury. So it's a nice little cascade of events. So clinical manifestations, classically, you will see fever, tachycardia, chills, petechial rash, as well as nuchal rigidity, photophobia, and severe throbbing headache. There is sometimes projectile vomiting. The petechial or purpuric rash, it will cover the skin and mucosal membranes, a sign that there's increasing intracranial pressure, and also papillate edema, then delirium, and then death. Also, which is of note, they will have a positive Kiernig and Brudzinski sign. Remember that from nursing assessment. Next is a brain or spinal cord abscess. This is localized collections of pus within the parenchyma of the brain or spinal cord. Develop in about 1 for every 100,000 hospital admissions, usually in middle-aged men, usually open trauma or during neurosurgery. Infection from the middle ear, otitis issues, nasal cavity, nasal sinuses, so a direct invasion there. Brain abscesses, they can be further classified into extradural versus intracerebral. The intracerebral arise from a vascular source usually. Spinal cord abscesses are epidural or intramedullary, and they're basically osteomyelitis in the vertebrae. Present usually with a low-grade fever, headache, which is the most common, neck pain, stiffness, only mild nuchal rigidity, some confusion, drowsiness, maybe some sensory deficits, communication issues. Later, as it gets worse, they will be easily distracted, memory deficits, decreased visual acuity, and narrow visual fields. If you're looking at spinal cord abscesses, there's 4 stages, and they're listed there: spine aching, root pain, weakness, and then paralysis. Encephalitis, this is a pathological state of brain parenchyma dysfunction, usually viral origin, nervous system involvement. Most common causes are mosquito-borne viruses, HSV1. They infect the specific cell types in the CNS. Then you have meningeal involvement and present in all encephalitides. So then you'll have edema, necrosis, with or without hemorrhage, increased intracranial pressure, manifested by mild to life-threatening fever, delirium, and confusion, unconsciousness, seizure activity. All right, this is last for the CNS. Woo, we made it. All right, cranial tumors. You already know the basis of cancer, so we're not going to spend a lot of time on that. We're just going to do some highlights of certain tumors. So within the cranium, either can be primary or metastatic. Primary are intracerebral tumors that originate from the brain substance. So those are neuroglios, neurons, blood vessels, connective tissue within the brain. Extracerebral tumors originate outside substances of the brain. That's meningiomas, acoustic nerve tumors, and tumors of pituitary and pineal glands. Metastatic, these are found inside and outside the brain substance, but obviously it's not the original cancer. So the gliomas are kind of the classification of these 4 that are below it here. So the astrocytoma is anywhere in the brain or spinal cord, very slow growing but invasive, and obviously the cell of origin is the astrocyte. Glioblastoma, multiform, predominantly in the cerebral hemisphere, highly invasive and malignant. Bad one. And they are thought to arise from mature astrocytes. Oligdendrocytoma, most common in the frontal lobes, may arise in the brainstem, cerebellum, or spinal cord. They are relatively avascular, tend to be encapsulated, and more malignant form is called oligdendroblastoma. So blastoma is never a good word. And they originate in the oligdendrites. Then you have, a lot of times, these patients will have focal deficits depending on that location, then possibly some cerebral edema leads to increased intracranial pressure, diminished cognitive functioning, headache, vomiting, seizures, papilla edema, unsteady gait, and then loss of sphincter control. Childhood nervous system tumors: medulloblastoma, epididyoma, astrocytoma, brainstem glioma, optic nerve, neuroblastoma, and retinoblastoma. Brain tumors are the most common solid tumor and most prevalent neoplasm in children. Brain tumors account for about nearly 20% of all childhood cancers, with an annual incidence of 2.4 to 4 per 100,000 in the United States. Largely unknown, there is potential genetic, environmental, and immune factors have been implicated, as well as maybe some familiar tendencies, exposure to radiation, oncologic viruses, and maybe chemical carcinogens. Everything we talked about, right? Alterations in embryonic development may play a part as well. They just really don't know. 2/3 of all pediatric brain tumors are found in the posterior region of the brain. Astrocytoma for child, same thing, from the astrocytes, slow growing, solid, very large, usually before diagnosed, and there's varying degrees of malignancy. Epididymioma is the epididymal cells that line the ventricles, and they are circumscribed, usually solid nodular tumors. Medulloblastoma, that is an infiltrating glioma, cerebellum, can extend into the 4th ventricle, rapidly growing malignant tumor, and then it can also go outside the CNS, so that's not a good one. Optic nerve glioma, optic chiasm, or optic nerve, that is associated with neurofibromatosis type 1. Slow growing, low grade. Brainstem rises from the pons, and then it can compress cranial nerve 5 through 10. Neuroblastoma and retinoblastoma are classified as embryonal tumors, so they will arise during embryo stage. Neuroblastoma involves a defect in embryonic tissue diagnosed during the first 2 years of life. 75% are neuroblastomas are found before the child is 5. They can be diagnosed at birth with metastasis metastasis apparent in the placenta. It is more common in white children versus black children, and this accounts for only about 8 to 10% of pediatric malignancies. Retinoblastoma is a congenital eye tumor of young children, originates in the retina of one or both eyes, is inherited or acquired. The inherited is diagnosed before the first year of life. The acquired is between 2 and 3 years and is often unilateral. They believe that more than 40% are inherited from an autosomal dominant trait with incomplete penetrant. Extracerebral tumors, meningioma, nerve sheath, brain metastasis is 10 times more common than primary tumors. Spinal cord tumors, I talked a little bit about intramedullary versus extramedullary, present about 2% of CNS tumors, and intramedullary tumors are within the neural tissues. Extramedullary are outside the spinal cord. For these, they're classified as astrocytomas or epidyminomas, gliomas, usually able to resect them. You can have metastatic spinal cord tumors. Those are usually carcinomas, though. We'll start with pain, sleep, and temperature regulation, then we'll get into some sensory later on. Pain is very complex, comprised of a pretty dynamic interplay between physical, cognitive, spiritual, emotional, coping mechanisms, environmental factors, and it involves pretty much the whole system. Unfortunately, it's also very subjective. That's one of the problems that we had, and especially when we made it the fifth vital sign, opioid problem, and where we're at right now. We do know that pharmaceutical companies also went to the doctors and said, hey, these pain meds, there's absolutely no way that people will get addicted, put them out like candy. And we obviously know that is very false now. There are a couple different theories related to how pain is transmitted. But again, we don't know for sure. So we're going to go into a couple of these pain theories later on. First, with pain pathophysiology. There's basically 2 types of peripheral pain fibers, and they transmit to the spinal cord. They're called A delta fibers and C fibers. We have 2 pathways that transmit from the spinal cord to the supraspinal areas. That pathway is from the lamina into the dorsal horn of the spinal cord to the hypothalamus and then to the somatosensory cortex. The effective pathway, then dorsal horn, spinal cord, hypothalamus, amygdala, and cingulate area. Those are the basic 2 pathways. There are afferent pathways, we have efferent pathways, and then we have an interpretation center. When we're talking about afferent pathways, that's what begins in the peripheral nervous system, travels the spinal gate, and goes into the central nervous system. Here is kind of a picture of that pain process. So we're talking about delta fibers, fast, sharp electrical impulses. C fibers more on that dull, achy, burning sensations and poorly localized. Often constant too. When we talk about chronic pain, it's usually C fibers. So we basically have 3 portions of the nervous system that are responsible for the sensation and perception of pain. We have that afferent pathway, which begins in the peripheral nervous system, travels to the spinal gate of the dorsal horn, and then ascends into the higher centers of the nervous system. We have the interpretive center, which is within the brainstem, midbrain, diencephalon, and cerebral cortex. Then have the efferent pathway that then takes the information back down. So that's descending from the CNS back to the dorsal horn of the spinal cord. The process of potentially harmful, which is known as noxious stimuli through the normal functioning nervous system, is called nociception. So then once the tissue is damaged by the exposure to either chemical, mechanical, thermal, noxious stimuli, this causes activation of the nociceptors. We then get 4 phases: transduction, transmission, perception, and modulation. So pain transduction begins when the tissue is damaged by the exposure at the nociceptor receptors. They're free nerve endings in the afferent peripheral nervous system. They selectively respond to different types of stimuli, and they are located throughout the body, but they are not necessarily evenly distributed. So after pain transduction, we then go to pain transmission, and that is the conduction of the pain impulses along the fibers into the dorsal horn of that spinal cord. So we have that painful stimulus. Now we're going into the dorsal horn here. Both of your nociceptors, so your responses are going in with that. So they form a synapse in those interneurons in the substantia gelatinus and cross the midline of the spinal cord. Then ascend to thalamus, and that's the major relay station of that sensory information. Brainstem, cerebral cortex can get there through multiple pathways, but as you can see here, just to get the gist of the pain perception pathway, this is what we look at. Then it gets to the lateral spinothalamic tract, and that's where we get to more processing. There's that cingulate cortex, there's that limbic system, and the somatosensory cortex. So that's what we're talking about here. So activation of those nociceptors then causes ion channels such as sodium, calcium to open. That creates electrical impulses that travel through two primary types of the nociceptors, which we talked about, the A delta and the C fibers. The delta fibers rapidly transmit sharp, well-localized, fast sensations. So remember that the delta is the fast. The C fibers are unmyelinated and they transmit dull, achy, burning sensations that are poorly localized. So those are the major, the two differences with that. All right. So then we have pain perception, which is the conscious awareness of pain. Occurs in the brain and the reticular system, as well as the limbic systems and the cerebral cortex. All right, so everything that's listed up here helps with that perception of pain. Interpretation of pain is influenced by many factors, including cultural preferences, male and female roles, life experience, past pain experiences. So are you one of those people that they say, oh, I have a high tolerance for pain? So all of that plays in with how your brain is going to interpret and perceive the pain that is coming in. So those three systems interact to produce the perception of the pain. This is called the sensory discriminative system, and that is mediated by the somatosensory cortex, responsible for identifying what is the character, the location, and the intensity of the pain. So then it's mediated through the reticular formation system, the limbic system, and the brain stem. And we call that the cognitive evaluative system, which basically is the individual's learned behavior and therefore can modulate that perception of pain. So the last step is pain modulation. So that is many different mechanisms that increase or decrease the transmission of that pain throughout the nervous system. Depending on what mechanism it is, modulation can occur during or after the pain is perceived. So that is the basic steps: transduction, transmission, perception, and modulation. So when we talk about then the modulators of pain, those are what are found in the pathways. And that mediates information about the painful stimuli. So in the nervous system, we're talking about prostaglandins, bradykinin, there's things called lymphokines, substance P, histamine, glutamate. You can see these listed down here. So those can increase or decrease the modulation of the pain. Some of the substances that sensitize the nociceptors in the peripheral nervous system, that is called peripheral sensitization. If it's in the CNS, then it's called central desensitization. That leads to an increased responsiveness and reduced threshold of those nociceptors to cause them to fire with increased frequency, resulting in what is called hyperalgesia, basically a increased sensitivity to pain, so a heightened response to painful stimuli. Allodynia is the perception of innocuous stimuli. So you can get a buildup of repeated stimulation of those neurons in the dorsal horn, and that is called the wind-up. And then that can actually result in pathological changes in the CNS, central pain sensitization, prolonged pain, increased sensitivity to future pain. So that's how our past experiences can change our future pain modulation. Glycine, serotonin, norepi, and endogenous opioids, which would be your enkephalins and endorphins, inhibit central nerves so that they can decrease that response. Of note, the endogenous opioids are a family of morphine-like neuropeptides, and they block transmission of pain impulses in the spinal cord, brain, and medulla. They also inhibit excitatory neurotransmitters such as substance P in the dorsal horn, and they may also be responsible for just that general feeling of good. So then with the neuromodulation of pain, we also have this descending inhibitory pathway. So we're now on the way down, and they also inhibit pain. So you have inhibitory on the way up as well as on the way down, and that's where a lot of our opioids work. When we look at neurotransmitters, a lot of them are amino acid based precursors. Here's just a couple of them, but those are the ones that I mainly talked about, breakdown of their physiological effect. All right, so we do have different pain sensations, so we'll go through these so that you understand it. Central pain is from a lesion in the CNS that usually involves the spinothalamic cortical pathways, which we just talked about. Constant burning, electrical quality, and that it's exacerbated by changes in the weather. You'll have that hyperesthesia, hyperpathia, or allodynia are usually present. It's very highly resistant to treatment. So when we think central pain syndromes, we're thinking about fibromyalgia. Referred pain is that originates from the visceral organ, and it may be felt in body regions remote from the site of pathology. One of the ones I think about is gallbladder. You actually can have posterior shoulder pain, and that would be an example of a referred pain. Another one would be appendix. In the beginning, it's actually around the umbilica, and then it will go over, but that can be a referred pain when you're actually having that around the umbilica. So nociceptive pain, we've already talked about. That's that activation of those nociceptors, and that is that chemical, mechanical, thermal noxious stimuli. Pain is usually clinically proportional to the degree of activation. This can be further delineated into acute or chronic. Chronic or persistent pain is lasting more than 3 to 6 months. Another way of looking at it is it lasting more than what should normally be a proper healing time. It often appears to be out of proportion with any observable injuries, such as lower back pain. So there are changes in the peripheral and central nervous system that cause dysregulation of those nociceptors. That's what I talked about earlier. That pain modulation leads to that chronic pain process. Malingering or maligning, and that is basically deceptive behavior and making falsification of those signs and symptoms. Be aware of it that, acute pain is not going to present the same as chronic pain, and, most of the time these patients are dealing with some type of pathophysiological thing, so just be aware of it. Empathetically mediated pain is usually accompanied by evidence of it. So edema, changes in skin blood flow, abnormal motor activity in the region of the pain, the allodynia, hyperalgesia, or hyperpathia. Deafferation pain is chronic, and this results from a loss of the afferent input to the CNS. This may also arise in the periphery due to a nerve avulsion or spinal cord lesions, multiple sclerosis. Neuralgia pain or neuropathic pain, lancinating, nerve damage, irritation along that distribution. This is usually what diabetics or cancer patients with chemotherapy get. It's initiated or caused by the primary lesion in the nervous system and leads to long-term changes of that pathway, called neuroplasticity. Often described as burning, shooting, shock-like, tingling, and is characterized by increasing sensitivity to stimuli. There can be, with neuropathic, there can be central or peripheral. An example of central neuropathic pain would be phantom pain or complex regional pain syndrome. Radicular pain, so this is usually from the nociceptor afferent fibers in the spinal nerve. Think sciatica. You can have radicular pain in your arm as well from a lesion or a issue with the nerve root anywhere pretty much in the spinal root. And then psychogenic pain is inconsistent with the anatomic distribution. There's no apparent organic pathology despite the evaluation. Of note, for pain in children, you must be aware that they are quite different in responding to pain or allowing you to understand what the pain is. There are classic ways that we do it. Cries was one of them, but it's really a subjective of who is bringing them in as to what's going on with them. But due to their limited cognitive and language skills, you really cannot say that they're acting appropriately for what may be going on with them. Once they're above 3 to 4 years old, pretty self-reliable, but again, they are children. toddlers, so they may underreport because they do not want to get a shot because that's the only time that they see doctors. Now, on the opposite spectrum, pain in the elderly, they also too may underreport, or they do not want to complain. They may mask new situations and because there's a fear of, they're going to get placed in a home or things like that. So we have a couple different theories of pain. So we have specificity theory, pattern theory, gait control, and neuromatrix. Specificity theory it was described by Descartes in the 17th century. And he proposed that there were specific pain receptors in the body that project to the brain, and then the intensity of the pain is directly related to the amount of associated tissue injury. So this was useful if you had a specific injury and the acute pain, but does not obviously talk about chronic or neuropathic pain or things that you cannot see. So this was pretty much discounted once we started getting into chronic cognitive emotional elements that related to pain theory. Pattern theory, that was late 19th century, and that was impulse intensity and repatterning of the central nervous system. This did kind of explain neuropathic pain, but it didn't account for many other pain theories. So he kind of built on that specificity and added the chronic pain, neuropathic pain kind of. The best one of to date, this is the one that I learned most about, and this is where multimodal pain control comes in, is the gait control theory. So with the gait control theory, it also built on the fact that we had non-nociceptive, which is the neuropathic, the central pain, and that could close the gait, and the nociceptive pain fibers would open the gait and increase the perception of the pain. And so the newest kid on the block is the neuromatrix theory, and this was proposed in 1999 because they were observing paraplegics and that did not fit into the theory. So what the neuromatrix theory does is that the brain produces patterns of nerve impulses that are drawn from those various endpoints, including genetics, psychologic, and cognitive. This is what we think about with phantom limb pain. So even though that limb is gone, it has been removed, the pain still is interpreted as being present. So once that stimuli has been removed, if you look at all the other theories, that does not make sense. But the neuromatrix accounts for that, and that is probably the closest one. So the neuromatrix builds on the gait control theory, but then adds the fact that there are it's burned into the memory of the brain that pain is there. Multimodal pain therapy is supposed to help this prior to surgeries. So that is what's illustrating basically the plasticity of the brain. So there is basically the gait control theory of pain. And then there's a picture of it. And as you can see, here are the gaits, and basically activating the non-nociceptor will close the gate to the nociceptor. So you have your large and small fiber impulses. It goes into the spinal cord dorsal horn, inhibitory interneuron. Excitation of it will block the pain and closes the pain gate. Inhibition of that will promote the pain and opens the pain gate. So chronic pain syndromes. Low back pain is actually the number one. But next to that is this myofascial pain syndrome, and that involves the injury to the muscles and the fascia. Muscle spasm, tenderness, stiffness. Musculoskeletal is obviously mechanical. We have neuropathic, we talked about that already. Fibromyalgia is more of a central pain syndrome. Chronic headache, 1 in 3 patients over the age of 65 are affected, so it's a problem. I just wrote down what things would maybe classified under each of the pain breakdowns. You can read that. We kind of talked about a lot of that when I was first going over it. All right, next up is temperature regulation. So hypothalamus is the control center for thermoregulation. It's achieved through the precise balancing of heat production, conservation, and loss. Maintain range around 37 degrees Celsius, 98.6 Fahrenheit. Normal range is considered to be 36.2 to 37.7. Some people run low, some people run high. Rarely do we get 41 degrees Celsius, but it does happen. Extremities are generally cooler than the trunk, and temperature at the core of the body is generally 0.5 degrees Celsius higher than surface. Their internal fluctuations related to circadian rhythm, as well as menstrual cycle. Gender has variance as well, lower during sleep as our whole body slows down. Temperature regulation is called thermoregulation, and it's by the hypothalamus mainly. We do have peripheral thermoreceptors in the skin, thermoreceptors in the hypothalamus, spinal cord, abdominal organs, and other central locations. Talking about body temperature rises, those blood vessels dilate, we have that heat loss to the environment, sweat glands secrete fluid, that a fluid helps evaporate and keep the body cool. Vice versa, if we are on the cold side, then we have constriction of the blood vessels, heat is conserved, sweat glands do not secrete, and then we have shivering and makes the body move and creates that heat. So children are different as well as elderly. For a child, they have greater surface area, they have slower sweat rates, they do have more brown fat. Sweating is also initiated at a higher temp set point, and it's more dilute. There's also slower acclimation to the hot environments, and then they have a decreased thirst response. Concerning infants, especially low birth weight, premature, they require special attention because of the body temperature issues. Normal term infants have that brown fat. Once they're older, though, they have little subcutaneous fat, and then they're not nearly as well insulated as adults. For our dissipation mechanisms, we have evaporation, conduction, convection, radiation. So you can see there, sweat evaporation, which is our primary mechanism, go about 600 kcal an hour. We have about a maximum of 3 liters an hour, and then it becomes much less effective if you're in a humid environment. Conduction, that's why we apply cold packs, and then cold water immersion is a very expedient way to dissipate heat. Convection, that is the fans that we use. That cooler air blowing across it can also dissipate with great. This is why we also want permeable clothing. Infrared dissipation, radiation, basically, we are reflecting the light away. Fever. Mechanisms of fever is not a failure of normal thermoregulatory mechanism. Fever is actually protective, and it is considered a resetting of the hypothalamic thermostat to a higher level. So it's not a failure, it's actually resetting it. So normal thermoregulatory mechanisms are raised so that the thermoregulatory center adjusts the heat production, conservation, and loss to maintain that core temperature at the new higher set temperature. So during that fever, we have vasopressin release, melanocyte stimulating hormones, corticotropin releasing hormones, and they actually act as endogenous antipyretics to help diminish that febrile response. So due to that antipyretic effect, the fever breaks, and then that return to set point is basically what happens. So remember how we been saying the whole way through this course is we have an on switch, we always have an off switch. We have actually antipyretics within our body, and that is what basically brings the fever back down. So what are the benefits of the fever? Obviously, we are trying to kill microorganisms. Also, it decreases serum levels of iron, zinc, and copper, which we learned are very important for bacteria to replicate. Lysosomal breakdown and autodestruction of cells with increased temperature, so that prevents viral replication and infecting the cells. It also increases lymphocytic transformation and motility of PMNs, facilitating more of an immune response. And then also phagocytosis is enhanced. So that is why it's protective. It's basically the body's job of trying to get rid of that microorganism. So we do have some dysregulation of this mechanism, and basically a fever is consistent with greater than 38 degrees Celsius or greater than 100.4 Fahrenheit. It's usually very important to have a fever with a focus. What we don't like are fever of unknown origins, and that usually happens in the hospital unless you have some rare case that happens outpatient. FUOs, infectious diseases, malignancies, autoimmune, and other. But you got to investigate everything. And child, it's usually related to rare diseases, but could also, remember we talk about the zebra, it could actually be a horse presenting unusually or atypically. Always thinking fever, chills, weight loss, night sweats, malaise, and pain. And anytime we have a fever unknown origin, we're always investigating etiology and have they gone anywhere. Malignant hyperthermia, this actually only happens with anesthetics, succinylcholine. So this is only going to happen in the hospital, but need to be aware of what it is. So this is related to a rapid rise in the body temperature. There's muscle rigidity, hypertension, and tachypnea. It's related to a RY1 defect, and that releases calcium in the muscle. And then we have oxidative metabolism within that. So it's potentially lethal. Usually have to have a volatile anesthetic or a neuromuscular blocking agent administered. The risk of it is 1 in 200. And what happens is that because of that release of calcium, we have uncoordinated muscle contractions, sustained muscle contractions. That will then create a temperature rise of 1 degree Celsius or 1.8 degrees Fahrenheit every 5 minutes. So you can obviously see how this can get out of control very quickly. Heat stroke, potentially lethal consequences, basically breakdown in overstressed thermoregulatory center. It cannot tolerate the temperatures of more than 40.5. Very high core temperatures, regulatory center ceases to function appropriately, sweating ceases, skin becomes dry, flushed, patient may be very irritable, confused, stuporous, or comatose, obviously at the end there. Evaporation of perspiration ceases, the core temperatures will then rise because we lose that convection. Children are more susceptible to heat stroke than adults are. Be aware of that, related to their higher surface mass, surface area to mass, and their difference in perspiring. Hypothermia slows chemical reactions. You can see the levels there, core temp less than 95 or 35 degrees Celsius. What happens then is we have slowed chemical reactions, increased blood viscosity, less blood flow then because of that increased viscosity. Then we also have coagulation factors and then profound vasoconstriction. The young and elderly are most at risk because they have less effective thermoregulatory mechanisms. And then also anybody that has a diminished ability to generate heat, such as hypothyroidism, hypopituitary, Parkinson's, RA, because of being unable to create that reaction. Depending on the severity, rewarming of the peripheral tissues may be the only treatment required. If you drown in cold water, it's much better than drowning in hot water. And if you are going to rewarm, then we have to actually do it slowly, no faster than a few degrees per hour. Next up is sleep. So active brain process that provides restorative function and promotes memory consolidation. There is a special area within the hypothalamus that controls the timing of the sleep-wake cycle, suprachiasmatic nucleus. We have the cycle called the circadian rhythm. It's a 24-hour rhythm cycle. And normal sleep has 2 phases that can be described and documented on the EEG, which is rapid eye movement sleep and non-rapid eye movement sleep. They then further divide the non-REM into a couple different stages. There is some the differences between the sleep cycles when we're younger. And then, all right, so we have wakefulness with eyes closed. That's when we have alpha waves, awake alpha waves. Non-REM sleep stage 1, sleep onset, we're drowsy, lower threshold for arousal at this time. This stage actually increases with age. We have more brief awakenings, and that's what accounts for fragmented sleep. NREM2 is light sleep with sleep spindles seen on the EEG. Non-REM3 is non-REM sleep, stage 3. This is when delta waves start, there is literally no eye movement, and then we get into REM sleep. So REM stands for rapid eye movement. This is the most restorative, the deepest. This is when a lot of our repair. So when we talk about what it looks like now, this is kind of the pattern we see. So we'll have stage 1, stage 2, stage 3, and then we have a variance coming back in, and then we get REM. And as you can see, then we don't get these deeper stages later on. We just go between the first 2 stages and go back into REM. So much different than we used to think happened. So that definitely has changed since I went to school. So there are some of the things that happen with non-REM and then REM. You can see over here we have provocation of medical symptoms, CAD, COPD, PUD, GERD, migraine, and cluster headaches related to the REM. Dysomnia, so we have a couple here. We have insomnia, obstructive sleep apnea, hyperobesity, hypoventilation syndrome, restless leg, hypersomnia, narcolepsy, and circadian rhythm disturbances. The insomnia, inability to fall or stay asleep, may be transient or related to time zone issues or acute stress. Long-term is usually related to drug or alcohol abuse, chronic pain, or chronic depression. Obstructive sleep apnea is disorder related to upper airway obstruction associated with reduced oxygen saturation and hypercapnia. That is related to obesity, male gender, and age. Very scary stuff. Loud snoring, gasping, intervals of apnea. There's usually an obstruction. It's caused by the soft palate, base of the tongue. Then you have collapsing of the pharyngeal walls, decreased muscle tone during that REM sleep. Obesity, hypoventilation syndrome, overweight, it's pressing on the diaphragm, and then we have decreased ventilation related to that. Restless leg syndrome is sensory motor disorder. There's a prickling, tingling, crawling sensation. It gets worse in the evening and at night to the point where they can't sleep related to it. Hypersomnia is excessive daytime sleepiness. It's associated with obstructive sleep apnea because of their difficulty sleeping, so then they will sleep during the day. And this is difficult because it may be while they're driving a car or working or talking. And then we have narcolepsy, which is primary hypersomnia of central origin. So daytime sleeps, also characterized by hallucinations, sleep paralysis, or cataplexy. And cataplexy is basically brief spells of muscle weakness or paralysis. They may think that this basically is related to maybe the hypocretin system deficiency and immune mediated. There may be a genetic component as well. Circadian rhythm sleep disorders, that is basically working night shift, jet lag. We are altering the time that we're supposed to be sleeping, and then that will make us have varying degrees of issues with trying to sleep then. This is something that you'll see a lot of. People don't sleep. What you need to do are sleep diaries, and then you can do further testing or watch them sleep. But 100 billion each year is lost due to unmanaged insomnia. So hypersomnia is the sleep disorder. There's multiple causes. There's also unknown causes. It all depends if you're going more idiopathic versus central versus medication. Idiopathic hypersomnia is actually pretty rare. It's 20 to 50 per million. And then when you talk more about secondary to OSA or medications, alcoholism, then you're talking basically about a secondary hypersomnia. There's a little bit more on obstructive sleep apnea. I already talked about it a little bit previously, so just delineating it further. All right, and there's restless leg. Sensory, so now we're going to get into the sensory organs. So vision, hearing, olfaction. All right, so taste, we have hypergeusia, ageusia, or parageusia. Touch, impairment, can alter reception, transmission, perception, can all alter that tactile sensation. And proprioception is basically your awareness of yourself in the world. Things that can alter that are vertigo, Meniere's, and then peripheral neuropathies. All right, quickly, external eye. What we're looking at blepharitis, hordeolum, chalazion, conjunctivitis, or keratitis. Keratitis are going to be your pathologies. The wall of the eye consists of 3 layers: sclera, choroid, and then retina. Retina is the innermost layer of the eye, contains millions of rods and cones, and those are special photoreceptors that convert light energy into nerve pulses. Your rods mediate peripheral and dim light vision. Cones are dense and they are related to color and detail. Choroid is the deeply pigmented area, middle layer that prevents light from scattering inside the eye. The iris is part of it, as well as the pupil where the light passes. And then there's also some smooth muscle fibers that control the size of the pupil to allow that light to come. Have vitreous humor, which is the gel-like substance that fills the vitreous chamber. You have aqueous humor, which fills the aqueous chamber. That helps maintain that pressure inside the eye. You can see the anterior chamber up here, and we have liquid there, and then we have the vitreous humor in this portion. So we have normal eye, bacterial versus allergic versus viral. There are the descriptions. So you see blepharitis here, which is inflammation of the eyelids, and that's caused by a staph or seborrheic dermatitis. A very itchy redness and some edema. Conjunctivitis, you all probably understand pretty well, and that is an inflammation of the conjunctivae, and that is bacterial, viral, or chemical, or allergic. Chalazion over here and a hordeolum. We used to call the hordeolum styes, and that's pretty much what they are. They're quite painful as well. One is the bigger gland that's in this with the chalazion, or with the hordeolum. It's a smaller gland that's more close to the eyelid. Results in reduced vision in the affected eye because there is cerebral blockage of the visual stimuli. The deviation over here is called entropia or extropia if it's downward or inward. So strabismus is one eye deviates from the other when the person is looking at an object. This is caused by weak or hypertonic muscles in one eye. Nystagmus is involuntary or unilateral or bilateral rhythmic movement of the eyes. It's usually present at rest or if the eye moves. You have pendular nystagmus as well as jerk nystagmus. Jerk nystagmus is one phase of the eye movement is faster than the other, and that can be an imbalance. Cataracts, incidence increases with age. We also have increased risk with certain pathophysiological issues. Basically, you see this normal lens here. With a cataract, you have a cloudy lens. Most common form of cataract is degenerative, but they also may recur because of infection, trauma, or diabetes. They cause decreased visual acuity, blurred vision, glare, and decreased color perception. Glaucoma, second leading cause of blindness. We have increased intraocular pressure. There are a couple types: primary open angle or acute angle closure. Acute angle closure is a medical emergency. Primary open angle is more on the chronic. So open angle is basically a type of glaucoma and the outflow obstruction of aqueous humor at the trabecular meshwork or canal of Schlemm. So when we're talking about the aqueous humor, so we're talking about in here is where we usually have the issue. With angle closure, the type of glaucoma, acute angle glaucoma, is more of emergency because it literally is stopped and the outflow of the aqueous humor, and that causes sudden rise in the IOP. Macular degeneration, leading cause of adult blindness, classically presents white people age 55, sudden onset blurring or distortion of vision. You can have atrophic, which is dry, non-exudative, and neovascular, which is wet or exudative. Drusen is waste products from the photoreceptors. This is an accumulation factor. So we get the waste products and it accumulates, called drusen. Hypertension, cigarette smoking, diabetes, family history are all risk factors for age-related macular degeneration. Hearing. So the ear is divided into 3 basic areas: external, only involved in hearing; middle ear, involved only with hearing; and then the inner ear, which is involved with hearing and equilibrium. Your middle ear has the tympanic cavity, which is a small chamber in the temporal bone, and it has 3 ossicles known as the malleus, incus, and stapes. A Eustachian tube. The cochlea has the organ of Corti, and I don't even see the cochlea on here. Ear infection, so this is otitis externa. This is going to be outer ear or swimmer's ear, usually Pseudomonas or staph. This is pretty painful, and usually there's some nasty discharge or redness. There's an oral fullness and some hearing loss related to it. It's very common. Can be acute or chronic, infectious or non-infectious. E. coli is also involved there. Fungal infection, less common. It also can be prolonged exposure to moisture, which is swimmer's ear. Itching, swelling, clear drainage that progresses to purulent. You can then have otitis media, which is common, especially in small children, and that's usually strep or influenza or moraxella. And you can have some predisposing issues with allergies. Olfaction and taste. Olfaction is related to cranial nerve 1. Taste, also known as gustation, is multiple nerves in the tongue, soft palate, uvula, pharynx, and upper esophagus. So there is a strong relationship between smell and taste, and that creates the sensation of flavor. There are about 7 different primary classes of stimulants that we've identified so that we smell and can identify, I guess, or classify. Camphoraceous, musky, floral, peppermint, ethereal, pungent, and putrid. And then the primary sensations of taste are sour, salty, sweet, bitter, and savory. So unfortunately, this decreases with age. Remember, those older people tell us nothing tastes good anymore. It's usually because we lose our olfaction and taste receptors. Also, some things that happen with aging and our loss of olfaction and taste is usually around 80 we decline in the sensitivity to odors, which may lead to diminished appetite and may alter nutrition. They also have an inability to smell toxic fumes or gases, and that poses a safety hazard. So there are some definitions. Hyperosmia is impaired smell. Anosmia is no smell. Complete loss of smell. Parasomnia is a perverted or abnormal sense of response to that smell. Taste can be altered by injury or impairment to the hippocampus. When we're talking about touch, we have 4 afferent fiber types that mediate tactile sensation. This develops before birth and continues into early adulthood. That it will gradually decline after that, as we lose the ability to sensitize our tactile function. Anything that interrupts or impairs reception, transmission, perception will then alter and give you tactile dysfunction. Proprioception depends on impulses from the inner ear and receptors of joints and ligaments. Progressive loss of proprioception has been reported in elderly. You can have some issues with spinocerebral tracts, the dorsal columns, vestibular dysfunction, or neuropathy. This would be vertigo. This is sensation of spinning that occurs, and that is usually the room spinning around. Peripheral neuropathies cause proprioceptive dysfunction. Renal disease, diabetes would be where you're leading towards that, and that's basically diminished or absent sense of the position or body parts. Think about their feet. They'll often have gait changes. Meniere's disease is a vestibular disorder that causes proprioceptive dysfunction. Don't really know what causes it or the pathological basis. If they get it, may be unable to stand or walk. All right, that's it.